Good evening, I'm Dr. Loy. I'm an orthopedic surgeon and a sports medicine specialist at Northern Inyo Hospital. And today's talk is a little bit about what is sports medicine. So first off, orthopedic surgery, what is that? Myself and my two partners, Dr. Robotic and Dr. Robinson, we take care of injuries about the bones, the joints, the soft tissues, ligaments, things like that. So all of us, if you get hurt and you go to the ER, we can all take care of that. And then my subspecialty, which is what this talk is about sports medicine. So if you think about it, sports medicine is popularized on ESPN and with professional athletes, and it's taking care of those athletes and the ACL injuries and the soft tissue injuries. But really, if you break it down to what it is, sports medicine is about the soft tissue injuries about the body. And really, more often than not, it's older patients that suffer these types of injuries. So sports medicine doesn't necessarily mean you're a professional athlete. It can mean anything. So some of the common injuries that we take care of in sports medicine are rotator cuff injuries. So if you hurt your shoulder and you have a hard time moving it, that's one of those. Injuries about the knee. So if you're skiing, hiking, and you twist your knee and you didn't break a bone in your knee, but you hear that pop, those pops are the kinds of things that I take care of. And those pops can be your ACL, your MCL, or your meniscus. These are all types of injuries that we take care of in sports medicine. And one of the things with sports medicine is we've developed arthroscopic techniques to try to take care of injuries through minimally invasive procedures. So you can think the way we used to take care of rotator cuff injuries was to do an incision several inches across the shoulder, an open procedure. You look at the soft tissues, and now I perform a procedure with 4 or 5 holes about the size of your fingernail to fit instruments into the shoulder, and I inflate it with fluid, and then I use a scope. That's what arthroscopic means. You're getting into the joint with a scope. It's a wonderful field. It's a wonderful practice. I really enjoy it. And I think what might work best for us is if we have some questions from the audience, and if we go over some of the procedures that I perform and also some of the tools. I think you'll get a sense of the kind of stuff that we can do in sports medicine if you get a sense of some of the tools. So I brought some of those with me today, and I'll bring them out kind of one by one. Get back in the camera here. I'm going to set them down over here. So when I was saying that we make incisions about the size of a fingernail, I'm not joking. This is one of the instruments that we use for rotator cuff repair. And if you can see here, the background, it's a punch. So if you're going to put an anchor into the shoulder when you're fixing that rotator cuff that's torn off the bone and reattaching it, you can put this punch in there to then allow yourself to put the anchors in. I'm going to pass this around. You guys can look at it, but this is a punch, and it's much smaller than my finger, and your incision can be big enough just to fit a punch like that in. So that's the size of the incision that we're talking about, something quite small. And it's sharp, so be careful. And none of this has been used, obviously. And so, for instance, we're talking about a rotator cuff, and I'm also teed up some videos, which I'll show you in a minute, but it might make some of this make more sense. But if you tear the rotator cuff, and you think about it, the rotator cuff will be torn off the bone. So it avulses the tendon off the bone. And my job is to take that torn tendon and then reattach it. So we punch holes in the bone with that punch that I just passed around. And then we put this anchor in the bone. And you'll see here, this is actually a PEEK anchor. I think PEEK stands for polyether ether ketone, basically a really fancy plastic. There's also biocompatible ones, which will be absorbed in about 2 to 3 years. But you punch the hole in the bone with that punch that I showed you earlier. This has suture, and then the anchor holds that in place. So now I've got an anchor in the bone, won't come out, and the suture's coming out, and I can take those sutures and attach it into the rotator cuff and then bring that all back down so the rotator cuff will heal to that bone. So these are very useful. I use these almost all the time in the shoulder. And for bigger cuff tears, you use 2 rows of anchors. And again, same kind of punch that we showed earlier. You can use an anchor like this that has this eyelet. So you take the sutures that you already reattached into the rotator cuff, and you can pull it through here and attach this to a second row to really compress it down. And sometimes you need a 2-row technique, other times you don't. But when you do, this comes in quite handy. And so this is just a naked or empty anchor. And then still other times, especially if you're working on the front of the shoulder. So if I'm fixing multiple tendons in the shoulder and I'm working in the front of the shoulder, the subscapularis, you have self-drilling, self-tapping. So unlike the other ones, This has a small piece of metal, and before this, every other instrument there was no metal. So it's a very small piece of metal, but very sharp, and you can tap this in directly, self-drilling, self-tapping into the bone, and that way you can save yourself from losing your instrumentation and losing your visualization while you're working. So this is a very handy tool to use that I don't use frequently, but when I do, it's a wonderful one to have. So anchors are used all across the body. One of these instruments is just for the knee. So this is a quad tendon harvester. If you look into how you can repair or reconstruct your ACL, there's a lot of ways to do it. And I think one of the newer ways to do it is to use a quad tendon is my preferred technique. There's a lot of good ones out there. And I've always been trying to make it a quicker recovery and try to make people have, smaller incisions, less pain, less bleeding. And if you imagine you're trying to harvest something that you might need to have, 7 centimeters of tissue. So people used to make a 7 centimeter incision across the leg, but instead you can make a much smaller incision. And then if you use this correctly, you make about a 2 centimeter incision, and you can apply this, and then you can harvest and slide this up the tendon and harvest the tendon for yourself and get out a very robust, strong tendon and cause less soft tissue damage. So again, this one's also very sharp, so be careful, but none of this has been used. Someone else just arrived, but that is a quad tendon harvester. And
Dr. Will, you have a question?
Sure.
How are you visualizing all of this during surgery?
Right, so good question. So it's all arthroscopic, and I just didn't bring in a scope because we don't have a scope. So a scope is a camera, and the camera, if this were a camera, is roughly this size. And so through one of the incisions, you have the scope. So for instance, in the knee, you need at least 2 incisions. So your scope is in one, and then your working instrument is in the other. So you can look at what you're doing and then work with the other instrument. And in the shoulder, there's often multiple instruments. So you can have a scope sitting in somewhere, and I can have one of my assistants hold the scope, and I can work with 2 instruments while they visualize with one. And then you wonder, well, how do you actually see when the tissue, because you don't have, if you're feeling your own shoulder, you don't have that much space. We have a pump at the tip of the scope. There's a hole, and it pumps the fluid into the shoulder. So it insufflates the shoulder a little bit to give you some working space. And there's other tricks and techniques you don't usually need to use, but you can tent up the soft tissue if you need to. But really, it's just about the pressure on the pump and using the camera that sticks in there. But that's a good question. And it's actually quite good visualization. So some people will say open surgery is the gold standard. I think that is an older way of thinking. And I think the new way of thinking is that you get such good visualization, and if it's something that you can treat arthroscopically, you can see it quite well. But yeah, good question. And I don't think some of you hadn't seen this. So this is an anchor I was talking about earlier with sutures. So you can put that in the bone after you tap the bone with this. And then you have sutures sticking out of the bone so you can reattach something to it. And it's all really mechanical. So if you work in your house, if you go to Home Depot, I mean, it's just you're building stuff back together. A lot of what we do is with plates and screws, and that's kind of intuitive. And this is more up my alley. Yeah. Yeah.
So do you do robotic surgery, or do you do it mostly manually?
So yes and no. Not what you're thinking. If you're thinking like a Da Vinci or robots where you're moving your hands and the instruments we do that at Northern Inyo Hospital. In orthopedics, it's not as common, especially for arthroscopic. There's robotic assisted total knees and total hips. That's not kind of this talk. Okay. And for arthroscopic, no, there's not really a robot to do that. Although I'm using instrumentation, but it's always my hands physically holding the tool, okay, as opposed to turning around and grabbing something that then moves the tool. That doesn't really, not in my field, not now. And I don't think it'll get there that soon. Well, if we have a second, let's see if I can get this to work. So I'm going to try to share a screen and show a video. See if I do this right. So this video, I'm not sure the audio will work. I don't think it's necessarily that important. Is that sharing? Okay. So this is a meniscus tear. So if you think about, first I'll set it up. So if you think about a meniscus, it is the cushions in the knee. You can see that there. So the femur, which has been taken out of this picture, would be up on top, and those are the meniscus. The cushions on the right side and the left side. So you think about the femur. It's a big round bone sitting on a relatively flat tibia. So that's not good for articulating. So you want to deepen that socket. So those menisci are cushions that kind of deepen the socket and help create more surface area to disperse the forces, and it makes a better joint. And then you see the one on the right of the screen is not torn, but the one on the left, you see that tear. So that's a tear, all right? And are all meniscal tears symptomatic? No. Does every meniscal tear need to get repaired, which this video shows? No. But if you have a torn meniscus and you want to get it repaired, this is one way to do it. And this is almost exactly how I do it. This is the same instrument, the same thing, and you'll see that they're going to use an instrument to put in a suture with a soft tissue anchor on the back side, and then they're going to put it through one hole, bring it over, push it to the other side, and you're going to have two pieces of anchors on the back side of it. So for everyone that's here, you're going to have an anchor back here and an anchor back here, and then suture crossing it, and then you're going to compress it. And rather than some of the older ones would have plastic in the back, this is all soft tissue, and I think it's quite functional. And I don't know how this will go as far as playing videos, so hopefully it's entertaining, but this is about a minute. I've got a couple other videos that are pretty short as well, so we'll see. Is that audio coming out? I'll turn it off here. But anyhow, this is the delivery device. So you insert it, you want to get good tissue and cross that tear so that the tear doesn't propagate and become symptomatic. And well, it was symptomatic, that's why they came to the office. You deploy it. That anchor comes out, you set it up, you pull it, stays, it expands so it doesn't come out with you. And then you deploy it again, and now you're getting a sense of it. You're like, oh, now I got suture crossing the tear. And then when you get it out, you tighten it, and you can tighten it under visualization. So that what they don't show you is you have to have your scope in the other portal, and you're looking at all this. You're visualizing it, you're looking straight at it. And then when you tighten it down, that tear tightens up. Usually tears don't get repaired with just one, it's like 2 or 3 of these. But when you do that, you take this torn soft tissue that historically would have been ignored or cut out, and now we can repair it.
Wow.
So that's a meniscus repair. It's less exciting to show you a partial meniscectomy, but if you have a tear that's not conducive to a repair, a partial meniscectomy is going in there and taking biters and shavers and then debriding that, which is less exciting to talk about. And we were talking earlier about the ACL. So this is actually an ACL procedure. So the ACL is inside the knee, and it stands for anterior cruciate ligament. So you've got 2 cruciates and 2 collaterals. And so the anterior cruciate ligament stops your tibia from sliding forward underneath your femur. And if you're healthy and you've never torn your ACL, then you don't know, and it feels great. But if you've ever torn it, you can feel like your tibia slides out from underneath you. And so this shows how to take a graft and reconstruct it. And not all ACLs need reconstruction. Sometimes you can do a repair, which is uncommon, but the technique that I do. And then the question is, if you are going to do a reconstruction, where do you get the graft? The 2 main questions are, do you take the graft from the person, an autograft, or do you take the graft from something else? Allograft, other. So allo means other, and the other is a cadaver. There's pros and cons to each. And for both, I actually think that in my hands, I like the quadriceps. So an autograft quadriceps or an allograft quadriceps. I think it's a very robust tissue, and I like the way it works for a lot of reasons. But let's see how this video plays out, and I'll show you what they're doing in this one. All right. Brian, if I have the audio off, do they hear it on the live stream? I have to turn it up. They wouldn't hear it anyways.
What they're hearing, what yours is playing.
But I mean, do I have to have my volume high for them to hear? Okay. I'll just talk. So this is just getting us through the anatomy, and that's the ACL, and it might be boring for the next 20 seconds, but it's going to get into how you repair it. And I think the kicker here is this device. So now I stick that in through the front of the knee through a small incision, and then from the outside of the knee, another small incision. These are the size of the tip of your fingernail, and you drill in a hole only 2 millimeters in diameter. And it's called a flip cutter. So once you get in, you'll see that it flips. And now I've got it exactly where I want it, because I can see the inside of the knee, because I have a scope in the front. And I'm looking inside right here, and I'm staring right at it. I actually have this same view. And I flip it, and they'll flip it here. And then I drill only what I need on the way out. So I'm not making a big hole from the outside in. I'm making a tiny hole from the outside in, and then I'm making the hole that I need from the inside out. So if I've already harvested your graft, I already know the length of the graft, I know how long I'm in the tunnel, so I'm not wasting bone, because people had a lot of bone pain after a procedure when they're violating too much of the bone. So this preserves your bone. And then pass sutures, because now it's just a management of tissue. You have to have sutures to pull things. You have to do everything under tension. And then they repeat the step exactly as I do for the tibia, although I can't just do it in a flash like that. But and then the graft. And I think here they might actually put in an internal brace, which I don't always do, but I do sometimes. And they'll fix it with buttons on the outside. So now it's called the suspensory fixation method. So you're hanging it from the outside and then dunking it into the tibia. And then you'll see that when you pull these sutures, it's a tensioning device where it can only pull one way. So you're tightening it. And then you don't actually have to tie knots. It's all knotless. So there's nothing that you can palpate. And this is all done through, this whole procedure would be 4 incisions the size of your fingernail. Because you can get in, basically the incision needs to be big enough to fit that button in. That's about as big as that incision is. And then you'll see that they tighten it. And it's called a reverse tightrope is their branding of it. But essentially it's a one-way pull with sutures going through themselves and they can't back up. That's a cool procedure.
Yeah.
That's one of my favorites. Are you guys enjoying this? Should I play another video or okay, just do it. And then we started off talking about the rotator cuff because I think that's most of the tools I brought. And actually we'll hand these out one more time so you'll see. So these are the 2 main tools for fixing it. So you're going to have a medial and a lateral row anchor. So medial just means like closer to midline. So you need to punch a hole into the greater tuberosity where the rotator cuff previously was inserted but got torn off. And now you're going to have sutures sticking out of the bone. And then you're going to take those sutures through the tendon and drape them back over to a lateral row. So you have 2 rows of fixation, you're compressing it down. So sutures need to go medially, so close to the midline, and then a lateral row over here to drape it over and down. So this is why these are different. One's got sutures and one doesn't. But you can get a sense of it. And there's extra sutures in there and stay sutures, which are really helpful. So here you're looking, this is going to have 4 separate incisions, similar to how I do it.
When did these procedures kind of come into, I mean, how long have they been doing these?
Arthroscopically like this? Yeah. Gosh, I don't know when it started, more than 20 years, but it's become much more popular in the last 10 to 15.
Because it's less invasive and a quicker recovery, or not necessarily?
Yeah, so it's funny. So the literature, it's always mixed in the literature as far as having outcomes that are quantifiable. But yeah, people have a quicker recovery, they have less pain. And for me and in my hands, you have much better visualization this way. You're looking straight at it through tiny holes and you think, well, you can't see much. Well, you're putting the camera in there and all of a sudden you see the whole world. Now, the camera, you can have a 30-degree or a 70-degree camera. So what that means is when you're looking, you're actually looking 30 degrees to one direction. So you have to get used to that. But then you just roll your wrist and you can see 30 degrees in all directions. And if you can't see enough, you can get a 70-degree scope and then you can see 70 degrees. So really you can see what you need to see. Let's see. Let's back up just a smidge. How much is a smidge? That's like a baking term, right?
So almost you can see better, you're saying, than if you were to open it up, because you can get in there.
Yeah, I definitely could. I bet you, I mean, there's probably no one watching that like is an orthopedic surgeon that does open cuff pairs, but they'll say they could see better open. You just see better. You can see everything because when you're putting your scope in there, you can move in different directions and I can see. So if you have an open incision, you only get to look through your one open incision. You don't get to make more incisions. The body won't tolerate that. But these poke holes, you put 4 in and you put the scope in all 4 spots so you can see this is the front of the shoulder. So you can do work in the front. And then you can put it in here and you can look everywhere. And you'll see patients of mine, they've got 4 poke holes in their skin. They look like the size of your fingernail, you know? I think the visualization is much better. All right, so this is going to some anatomy. And then when I was talking about it earlier, so this is a common kind of tear. So this is the tear where the rotator cuff, the patient's head would be over here, and the rotator cuff comes down. This is where it inserts. Tendons have to insert on bone to move them, right? Muscles, tendon, bone. So the muscle belly is here, it's not where the injury is, the tendon is torn off. So that was previously inserted right here. Okay, so our job should be to take that tendon and put it back. And people used to take soft tissue and tie it to soft tissue, but that doesn't like to heal. Soft tissue doesn't, tendons don't have a lot of blood flow. So what you do is, and I think they'll show it here shortly, is you debride some of the bone. So the bone is now bleeding. And now you take a torn tendon and attach it down to bleeding bone. So bleeding bone is going to send healing factors and stem cells and be like, hey, heal back down to me. It's a roughed up bleeding bone. It's going to want to heal. And so then I generally, if this was big enough, I would do 2 anchors on the medial row and 2 anchors on the lateral row. And the 2 anchors have sutures coming up and out. Then you drape it down. The whole tendon kind of sucks down with it to a lateral row. So it's compressed down. So I in my hands, I think about it that the medial row helps provide like compression, the lateral row helps take off the tension so you don't like confuse the sutures and confuse the anchors. I just want to get that as far over and it's draped down with a big footprint, and then you'll see, and it's exactly how I do it. And you know, patients, when I print out their photos afterwards, it makes like an M shape. So if you're thinking that you've got, let's see, you've got a torn tendon like this, that's 10 times bigger than life size, and you're trying to get it back to here, then you put 2 anchors down on the inside with sutures coming up, and then you have 2 anchors laterally, and then you guys still have that suture. So it's got 2 limbs, the one I showed you, right? So a left and a right side, and if they both have 2 limbs, you pass the 2 limbs up here, and then 2 limbs up here, and then you cross it, so the limbs gets divided.
Oh, gotcha.
And then by this time, the tendon has been, you've pulled the tendon all the way over. But now you can imagine if that's where the sutures are, you're dispersing the forces pretty evenly, as opposed to, and no one would really do it this way, but they used to, as opposed to grabbing one suture, tying a knot there, pulling it over to 1 anchor. That's not, it's just not compressing, it's just not as good. This is a much more robust, biomechanically stronger repair. And sorry. Okay, so I think now they're going to get to preparing the footprint. So in this one, they've got the scope in the back, which is exactly how I would do it. And they're labeling everything, and they're going to get in there, and they're going to show you a burr. Well, that's just showing you that they can retract the cuff. Then they get in a burr, and they prepare the bony bed. This is the burr. So now you got bleeding bone, right? We were talking about that earlier, how it's probably going to help it heal down. And then we're going to put 2 medial row anchors in. Medial just means closer to the head, closer to midline. And there you go. That's the exact same device I was just passing around. You turn it in. And while you're tapping, remember that punch I handed you guys earlier, it all kind of matters. So when you're tapping, everyone's different and every part of the bone is different. But if it sounds really like firm, robust bone, then you have to tap it. So if you're, mechanically inclined and you're drilling something in the wood, then you can send a tap down. Tap is like a screw you send down before the screw, so you can tap it so you don't break this peak anchor, this anchor that's could break. But if it's softer bone, then you don't even put your punch all the way in, and you don't put a tap in because you want a good strong bite. You want it to like start to squeak as it's going in, so you know it's a good bite. So they've done that. Now they're retrieving the sutures, and they're going to magically have a second anchor show up. And then you're going to have your 2 medial row anchors, and they're going to drape it over to a lateral row. And they're passing those sutures. That's called a scorpion. So sharp needle takes the suture up, you pull it out, and they're just getting them out of the way. This is just suture management. This is just so you don't, cloud your field of vision. And so now, as I explained earlier, you got the 2 limbs per each. It's going to take 1 of each limb to create that crossing thing that I was talking about. So that's this, create that cross. So you're just dispersing your forces, and then you don't get what's called dog ears. If you're trying to tie something round to something flat, it's going to want to dog ear and bulge up, right? Round things don't go to flat things. So you have to take that into account. And you can always use an ancillary stitch to compensate for that, which these all have. So this is why I like this anchor. This is an extra stitch if you needed it. So if you see a dog ear come up, you use this stitch, already part of your anchor, and you can grab it. I forgot, they do it in this video. So, and they do that. So theoretically, if now you think that was gonna be a dog ear, they use the extra stitch. Oh, that one wasn't built into the anchor, but it could have been built into the anchor. And then you could have it, fix that dog ear, fix the extra piece that was not gonna be tethered down. And then you can imagine if you're screwing and this, sutures are in place, the screw will tighten that suture, it'll take it with you and create compression. And then you repair the torn tendon.
Wow. Dr. Lloyd, you have a question?
Sure.
Are there any clinical situations where you can't do this repair, like with osteoporosis?
I was just gonna ask you.
Good question. So, yes, and then obviously there could be a situation, but then the second part, no. So the yes part is a chronic tear that someone decided not to treat surgically 10 years ago. And then the debate is, well, your shoulder's not functional because your rotator cuff doesn't move it. Do you need an arthroplasty? But without a rotator cuff, you can't get an anatomic total shoulder. So you need a reverse total shoulder, both of which I do, anatomic total shoulders and reverse total shoulders. So then do you need to have a superior capsule reconstruction, which is a kind of rare procedure, but something I do. And I like super subspecialized in it in my fellowship training. We did a lot of superior capsule reconstructions. And so superior capsule reconstructions, if you have no rotator cuff that you can repair and you don't want to go forward with the arthroplasty, then you can put a dermal allograft on top. So you have no rotator cuff. And so what that rotator cuff is doing is draping from your shoulder over your glenoid and then to your humerus. And you just put a dermal allograft from your glenoid to your humerus. So the glenoid and the humerus are a ball and socket. So you put a graft and now you have no soft tissue on top. So if you have no soft tissue, you can't lever off of anything. It's got nowhere to go. It's just going to slide up. And that's why people who have chronic rotator cuff tears, they don't lift their shoulder all the way. They kind of shake hands like this, and they can't get their shoulder up. So you can put a superior capsule on top. Okay. So the first part was, are there clinical situations where you can't? Yes. In osteoporosis, is that really one of them? Well, it could be. However, I only brought some of my toys, and man, we got so many cool toys in the OR. It's awesome. And this, if you look at it, is I call the 4.75 millimeter swivel lock. It doesn't matter. The 4.75 is what matters. So 4.75 millimeters in diameter, and I have a lot bigger anchors. So yes, I've done that. So I've been putting in anchors, and I've done revision surgeries where someone had it done elsewhere that failed, and they needed to come in. And if you have too many anchors in there and you start to get cysts, then you don't get fixation. So I talk about that where I'm tapping. I've been in there where I start to tap and I don't even have to mallet it. I just push it in and go, oh, that's way too soft. So then I bypass the small anchor and I use a bigger anchor. The bigger anchor fills up more space, and then you are impacting the bone. So the bone's going to go somewhere. And if there's not enough bone to get good fixation on this, you put a bigger one in there, it's going to compress it to the side. So yeah, and then if that weren't going to work, that's not really proper, sorry. So then you could use bone tunnels. So if you can't use an anchor, you can drill a hole through the bone, take the suture through the bone and tie it on the outside of the bone. So it's kind of hard to explain, but let me see if we can get this picture up here. So for instance, let's just say you're starting to put this anchor in and it fails. And then in my hands, I would get a bigger anchor and it fails. Well, hopefully I figured it out before then, but the other option is if the osteoporosis is so bad you can't do it, then you can drill a hole, and it's a curved instrument to drill a hole out through better bone down here because the head is softer bone, this is better bone. Then you take the sutures out through here and tie it over a bone tunnel, a bone bridge rather, and now you've got the sutures coming down through better bone and you tie it over bone without an anchor.
Do you usually know if you're gonna have that problem like from X-ray prior? Or?
You have a pretty good sense of it, and you definitely have a good sense of it before you're like on your third attempt at an anchor. You're like, okay, let's not do it this way. But really uncommon. So rotator cuff tears happen more often in, this is a sports medicine talk, and it's not for, rotator cuffs are not the most common thing for professional NFL players. It's more common in older people with attritional injuries who also have some osteoporosis, which is why we have all these anchors designed. It's already been taken into account. And there's, every time I go to the OR, it's plan A, B, and C, and D, and that is like plan D because A, B, and C work 99% of the time.
How long would a procedure like this take on average, would you say?
Yeah, so that one, if that was it, and it was just a 4 anchor repair, I did one last week, I think it was 45, 55 minutes. If it's also working the front of the shoulder, it's another 20 minutes. If it's a bicep tendon as well, it's another 10 minutes. So 2 hours for a big one, less than an hour for a smaller one. roughly. Yeah. I mean, that's kind of sports medicine in a nutshell. Other stuff, you know, it's not that I always try to be minimally invasive, but a lot of the other stuff that we take care of and people like because they like quick procedures. You could go in there and do a devastating procedure on someone who had, a horrible car accident, and it takes you 7 hours. People are like, oh, it took you 7 hours. You're like, well, you did 10 things, but you go in there and you do a trigger finger, which is super easy, or you do a carpal tunnel release and it takes 7 or 8 minutes. Like, oh, you're a good surgeon. You're like, well, I mean, it's a simpler procedure, but all those, they all matter. So we do all that. All my partners do carpal tunnels and trigger fingers, and that's all very small and fast and not really sports, but just some of the stuff that we do, and it's common. So, yeah.
Dr. Loy, another question.
Yes.
What has your experience been with the US ski and snowboard teams?
Yeah. So it's awesome. First off, I like working with them. You get to work with people who compete for the United States. And I started working with them, I guess, 4 years ago when I was in Taos. So my experience has been that they email the doctors and they say, here's the events for this next 12 months. And we'd like to have help on XYZ places. And so last time it was in Chamonix, France, and you go out there and you're helping skiers ski, and it ends up not being all that much surgical stuff. But then my thought process is I'm out there and I just tell them, like, look, if you got hurt, I would make sure you got the proper care. So go ski your heart out. And then sometimes just going to practices, and that's where actually you get more injuries. But basically you're a team physician. You travel with the ski team for a week or 2 weeks. And then once every couple of years, you meet up with a bunch of the other surgeons who work with the ski team and you practice. So, God, where was I in Colorado? Somewhere in Colorado. I should remember. And it was, 4 days on the mountain, and you're just practicing, you're just rehearsing, getting people off the mountain, getting them ready to be helicoptered off, skiing them down. And everyone thinks it's like a decent skier, but it's hard to ski unless you're a ski patrol guy. I mad respect to anyone who does that, because it was hard to ski down the toboggan and whatnot and do it quickly. And it's not like the surgeon would have to be the one that does that, because there's always ski patrol, but we're just rehearsing and practicing to making sure that we can do it. And then, you just talk to local surgeons and you get plans. So I always take my job to be that if the skier gets hurt, he's going to get the best care as fast as possible. And that is learn how to say things in French or Italian or whatever, enough to get to the right hospital and calling hospitals and figuring out what privileges are and doing your homework.
Do you do men and women too?
Yeah. So a lot of times once you start that they want you to stay. And I don't know if I want to pick, because some people only do downhill and some people only travel with Michaela Schifrin. And I haven't decided to do that yet. So I ski and snowboard. So I kind of want to work with both skiers and snowboarders, male or female. I don't really care. No. Any other questions?
Have you seen, I know here in our, I don't know if it just seems like a lot of high school kids get these ACL tears playing soccer and stuff. And are we any worse than elsewhere, or the same? Or?
Gosh, so simple answer, no, it seems about the same. So I've covered high school sports for 8 or 9 years, and it seems about the same. And I see a lot, not a lot, but I think most of them, and that's what I do. But I don't think it's worse. I think it's about the same incident rate.
And then how about if, I just think that I can think of someone I knew like in high school that had one. What is it? I know that Dr. Murdick was talking about NFL players when that happened in one of his talks, but for a high school kid, is it kind of not really good news for later on towards college or depending? That just seems so young. Yeah, so it's a good question. So the short answer is no, it's not necessarily bad news. And we reference the NFL, not because the Bishop NFL team is so good and that Rich and I cover, but because the NFL has some of the best research. So ACLs, and I'm going to actually just watch Rich will correct me on this, but ACL alone in the NFL is not a death sentence by any means. And there are people who don't do well. Jerry Rice had a fracture. He had his patella harvested, which I don't like for that reason.
but Adrian Peterson actually had a better year after his. But in general, if it's an isolated ACL, they tend to go back to near or the level they were at before. But multi-ligamentous knee injuries, so multi-ligamentous, multiple ligaments, so ACL and something, and it's usually 3, but ACL and MCL, or ACL, MCL, PCL, they tend to not get back to the level. So if they are all-stars, pro bowlers, they tend to not get back to that level. If they were starters, they tend to get back to starting, but if they had 1,000 yards rushing, they tend not to get back. And then the position really matters. So if you're if you're a position athlete, so if you're a wide receiver, cornerback, running back, then your ACL matters a lot more. But then you see these offensive and defensive linemen, they have braces on, or Tom Brady. I don't even know if Tom Brady ever got his fixed, did he? Looking it for somebody. Well, Tom Brady's not fast, and he's still the greatest of all time. And he didn't have his ACL for at least for a while. And offensive linemen just they wear those braces. So that brace, what it does, it's got a strap on the front of the back of the tibia, and it prevents the tibia from sliding forward because the anterior cruciate ligament. So you want to keep your tibia from sliding anterior. But if you're a position player, you need that.
Dr. Lloyd, we have a question.
Yeah.
Are there more ACL injuries on turf or grass?
It's a good question. Who's asking that one? But I think there's an answer to that question, and I don't know. I think it would be turf, but I just don't know the answer. That's a very specific question. Good one.
Oh, another question. What
Mhm.
role does rehab therapy services have in athlete recovery?
Yeah.
Huge.
So that's huge. So I don't know how to quantify it, but a majority. So the surgery can be easy, can be quick. And it doesn't matter if you don't violate tissues or you treat everything with respect, and it's all nice, but the body likes to shut down. So after you tear your ACL, your quad, which if you think about what you're doing when you fire a quad, you're extending your leg, you're taking your tibia and sliding it in front of your femur. Well, your body got used to no ACL to keep your tibia from sliding. So your quad atrophies. Your body's like, don't fire that quad right now. But a big part of once we fix your ACL is to get your quad back to strength. And people will look at it, if people are watching that fix their ACLs, their quads are smaller for a while and they have to work on it. The other thing is anytime you have surgery in the knee and you insufflate the joint, like we showed in those pictures to visualize, then you've got fluid on the knee. If you have fluid on the knee, then the quad is like upset because the fluid's on the knee. So if you ever had a knee effusion, your muscles don't feel great. So you get quad inhibition because you don't want to keep walking on it, kind of hurts. And so if you have quad inhibition and the body is told the quad to shut down, and crazily, if you tear your right ACL, you have right quad atrophy and left quad atrophy. What? So yeah, it's huge. It's of the utmost importance. So you hear about these Adrian Petersons and everyone thinks they're that good. So good for you. But the reason why he got back is because it was his job to do it. So he was doing physical therapy like none other. And it's hugely important. You got to get your quad back to full strength. You've got to be able to do single leg squats. You got to be able to do everything you did before.
Another question.
In case it wasn't clear, very important.
Have you had any allergic reactions to the sutures?
So yes and no. So allergic reactions, sometimes you'll see people have like they break out. And we've had people who discover they have a latex out. We don't really use latex anymore. But I've had people that have spit sutures out and then you just take them out. So there's two main types of sutures. Well, absorbable and non-absorbable. So sometimes people react to one differently. And if people react to one, and that's in my hands, I say, we know you reacted to that suture. Tell every surgeon forever, this is a particular suture, and I give them a copy of the suture I used. I say, here is the brand, here's the label, take this. You did not like this, your body did not like it. But is it truly an allergic reaction, or did the body just spit it out as a foreign body? It's hard to say. But yeah, we've had problems with sutures, and it's not uncommon. If you do enough surgery, you're probably going to see someone.
So what are they made of? Nylon or?
Nylon's one, so that's non-absorbable. That's that black monofilament. There's all sorts of ways of describing suture, but then the absorbable sutures historically were catgut, and now they're called monocryl and biosin, and they break down. They lose their structural integrity over the next several weeks to months. And then this is 100% not absorbable. This is made of all sorts of types of like polyethylene and braided and whatnot. And that's how we describe sutures as braided and non-braided as well. But this is non-absorbable. These are both non-absorbable. You get a sense of it. But the stuff that you're talking about, that nylon, the black. So if you worked on the floor or whatever, you'll see those black sutures. Those are nylon. If they're monofilament stuff, it's really slick and it looks like one fiber. That's a monofilament.
Mm.
Oh, another question.
Mhm.
For student athletes, what concerns are there about early age ortho injuries and long-term issues?
Okay, so that's a good question. So one that comes up in general is like little leaguer's elbow. So you when I grew up, like you play all sports. You play soccer, you play football, you play baseball. But people start getting into one sport only, and particularly in attritional injuries like little leaguer's elbow, you overdo it, and then your body doesn't quite recover and compensate. So I think the main concern is protecting youth athletes because you don't want those injuries to linger. And then we've found that good body mechanics and good musculoskeletal control can save your ACLs, particularly like jumping and landing techniques. So people that for some reason have different biomechanics can be more prone to tearing their ACL. And sometimes kids, you see the kids, right, that like all of a sudden they grew 5 inches and they look gangly, like you got to get your muscles to catch up when their bones are growing that fast.
How about like swimming? Because it seems like when I grew up, women didn't have all these shoulder, I don't know if they necessarily need surgery, but.
I generally think of swimming as like one of the better sports that they can do. But yeah, so swimming and overhead activities can cause and exacerbate underlying shoulder pathology. So if you had a torn rotator cuff, swimming might not be the best, but in general, I do like swimming. I don't know if swimming is correlated to increased rotator cuff. It might be that we're more sensitive to it, or it might be that now that the surgeries are advancing, that people are more willing to pursue it. But I don't know if swimming is related to, like, increase in swimming is related to increase in shoulder pathology. I don't know about that, but might be.
Or maybe the weightlifting.
Yeah.
It seems like we hear about it more than we used to.
Dr. Loy, another question.
Mm-hmm.
What pre and post-surgery preventative measures are taken to reduce the risk of orthosurgical infections?
Yeah, so that's huge. So surgical site infections, fairly important. So preoperative, intraoperative, postoperative antibiotics are really important. And then just screening, right? People need to be tuned up and healthy. If it's an elective surgery and you're not in the ER, you should be ready for it. You should be optimized. So for people who have diabetes, it's making sure the A1C is well controlled. And for anyone else, the time to get surgery is not the day after your cat bit you, right where you're going to have your surgical site. And then staying clean. We tell people that generally speaking, if you have an incision, 30 days of no putting it in still water. So no sitting in ponds and hot tubs where you're going to have someone else's grime against your incision to get it infected. But antibiotics has been wonderful for orthopedics. They're so good now that it's decreased the surgical site infections, and those are huge. So surgical site infections are important to try to avoid. Yeah.
Which antibiotics do you use ideally?
Right. Okay. So ideally, I'll just go with the most common because we try good practices. So what bugs are we trying to kill? Often gram-positive, ones that live on the skin, because you cut through the skin after cleaning. So we always prep the surgical site. So Kefzol, Keflex is very common. And then people that will come in if they have a penicillin allergy. There's literature that shows that penicillin and Kefzol, Keflex type antibiotics, cephalosporins have some cross-reactivity. If it's a light reaction, we usually give it, but if it's the anaphylaxis, we move on to a second antibiotic, which could be clindamycin or it could be vancomycin. And we can keep going down that road. If people have more and more allergies and problems, we would find something, but those are the 3 most common. But Kefzol is by far and away the #1 most common.
And Dr. Loy, we have another question.
Yeah.
Is there any advice you would give to people who are new to skiing or snowboards in general on how they might avoid injuries? And are these something you see a lot of?
Know your limit and go watch some ski video and see people crash and be like, I don't want to be that guy. No, all joking aside. So I love sports and activities and I love doing stuff like to my edge of ability. So I'm not going to say that, but I will say this. And if my friends are watching this, they'll know this. So my friend's trying to get me to get this new mountain bike thing. And I've always told people, buy the protective gear first, and buy the most expensive, well, not the, buy the best one you can afford. And I bought a helmet before I got my bike because you've got to have the good stuff. Protect that helmet, the brain, MIPS, or any other kind of anti-concussion helmet. Get the new stuff, protect the head. Now the skiing and the legs, people, you know, it's a self-fulfilling phrase when you say that you always get injured on your last run, but the idea, well, right? Because so, but if you're fatigued, especially around the knee and the ACL, if your quad's fatigued and you're skiing and you start to get a little loosey-goosey, that's when you don't control your body mechanics and you can injure things. So careful after lunch if you have a stein full of beer. Don't go skiing and hurt yourself.
And I believe that's it.
All right. Thanks for joining me, guys. Take
Thank
care.
you.
Thank you.
Can I ask one more question?
Oh yeah, one more.
This is a little bit off orthopedics,
Sure.
but what is, I didn't know what you were talking about, the MIPS helmet,
Yeah, so what does MIPS stand for?
or I could just Google it.
Multi-directional protection system. So MIPS, I forget what it stands for. Someone Google it real quick. I'm just gonna Google it. But the MIPS helmets have like an extra layer. So the normal helmet, right? Boom, you hit it, it's got foam, it protects you. But people get concussions from twisting their head. That's why like when boxers punch and they hit the jaw, it knocks someone out, right? So it's the torsional injury. So the MIPS is, for lack of the actual terms, it's got this little extra layer that connects to the scalp so the helmet can rotate and your head stays the same, taking the injury from the ground or wherever you hit. And that protects you from the torsional injury from falling. Other people put little pads in the helmet to protect your head from rotating. But what did you guys Google MIPS?
Multi-directional impact protection system.
Impact protection. Okay. Multi-directional. There you go.
Oh,
Yeah.
I think you gave a little piece on that one time.
It's like
about-
3
yeah,
years
I
ago.
remember seeing that.
Yeah, someone brought in their Troy Lee Designs helmet, which is a nice one.
Yeah.
MIPS.
My daughter had a concussion on Easter, and then the ski guy, patrol guy handed it to me, and I go, oh, the neck thing's broken, and I realized, I guess she won't be using this.
Yeah.
And the guy goes, yeah.
Yeah, and that's another thing is that some helmets have a life, and it's often just one big crash and the helmet's considered done. So
One more question,
Yeah.
Dr. Wynn. Do we see a lot of traumatic brain injuries here?
okay, so that's a good question. So it depends on how traumatic we mean, but we take care of almost every orthopedic injury here. But if they have multi-system injuries, multi-traumas, and they need a neurosurgeon, we don't have a neurosurgeon, so some of that stuff gets flown out. But we do, and our primary care team does post-recovery and rehab, stuff like that.
Thank you.
All right, now bye.